Hi, I'm Nikita. I'm a third-year medical student at Nova Southeastern, and today I'm going to be talking to you guys about developmental approaches to chronic pain management. And one of the reasons why I wanted to actually talk about this is because I've seen a lot of people with chronic pain, and they are, the same kind of treatment modalities are used, NSAIDs, steroids, opioids, tricyclic antidepressants, you have anticonvulsants, sodium channel blockers, and sometimes it even goes as far as minimally invasive procedures. And all of those are shown to pose significant either short-term risks or long-term risks. Whether NSAIDs are used, you have risk of gastric ulcers, you have risk of, just bleeding, you have a myriad of conditions like renal failure, all of those. And then opioids, you have, the respiratory depression, you have the addiction, tolerance, and then minimally invasive, you have obviously, risk of infection, you have continual risk, and those are not, and none of these treatment options will actually treat the chronic pain. So you're still stuck with it. So some of the developmental approaches are limb kinase inhibitors. So limb kinase inhibitors can potentially increase the amount of delta opioid receptors present on the plasma membrane. So one of the mechanisms of action is the limb kinase naturally is going to degrade the intracellular cytoskeleton, but when you inhibit that, you're going to promote cytoskeleton rearrangement, and then that rearrangement will traffic delta opioid receptors to the plasma membrane. And when you increase the delta opioid receptor concentration, the amount of opioid you give can actually be significantly decreased because your threshold for reception is a lot bigger and greater. And this can actually decrease the rates of the consequent addiction, tolerance, and adverse effects of opioid therapy that we often see. And sodium channel blockers, specifically sodium 1.7 and 1.8, in mice studies, it was shown that when you have a knockout deletion of sodium 1.7 and 1.8, you have a significantly decreased perception of inflammatory pain. And sodium channel blockers like tricyclic antidepressants or anticonvulsants will actually block the propagation from periphery to central, and then that will diminish the transmission of pain into the central nervous system. So current treatment modalities that are being explored are the protoxin 2, tetrodotoxin, and pyrrolidine based compounds, and then all of these are currently in development. And this can actually allow for a selective targeting of sodium channels because our body has so many different sodium channels, but selective targeting of particular 1.7 and 1.8 can provide a potentially more targeted approach to what organ you want to treat the pain in. And you can tailor your therapy to that, which is something unique relative to NSAIDs, which are globally or more specialized, but opioids just kind of knock out pain in general. This is a more targeted approach. And you have recombinant granulocyte colony stimulating factor. So a unique property of neutrophils is when they recognize pain, it's a natural chemoattractant for neutrophils, but they actually have opioids that are endogenous to the body, and they naturally produce opioids. So when you are injured, you're kind of utilizing the chemoattractant properties of the neutrophil to bring in more endogenous opioids. So you can reduce the amount of exogenous opioids you have to administer. So that was kind of a finding in the research. So when you have mice models that were treated with the recombinant granulocyte colony stimulating factors, they increase neutrophil migration to site of injury, and the amount of endogenous opioid containing neutrophils went up, and that reduced the peripheral signs of nociception in the mice models. So that's another potential treatment option that we can use for chronic pain. And IL-1B receptor modulation. So interleukin-1 is a potent pro-inflammatory cytokine. So when we induce sciatic nerve injury into mice models, it was found that the P450C17 mRNA and pain perception, they will be consequently increased. So when we actually did IL-1B expression and induced the activation of IL-1B, it decreased the P450C17 expression. So by targeting IL-1B receptors and activating them, we can actually decrease the amount of pain because we're blocking a signal in this signal cascade. And TIM1 is similar to MMP or matrix melanoprotease, and all of those are also potent chemoattractants. So when we did TIMP1 knockout mice, they showed signs of mechanical hypersensitivity. But when we did recombinant administration of TIMP1, we actually were able to reduce the mechanical hypersensitivity by targeting the MMP1. So all of these studies, one of the most effective studies that I've seen in all of this research is the limb kinase inhibitor, because it's one of the only ones that can actually increase the amount of delta opioid receptors on the plasma membrane. So I think that will hold the most potential, but again, all of these are still, in development. More research is needed. But maybe a potential future direction would be to utilize multiple combinations of these. For instance, limb kinase plus TIMP1 or limb kinase plus sodium channel blockers to provide a more holistic treatment of chronic pain, because chronic pain isn't just through one pathway. There's multiple integration steps in chronic pain, as highlighted in the figure that I have. You have different factors feeding in, and all of them feed in and they integrate at multiple levels in the brain. So you have to target different levels in order to achieve a therapeutic approach. So I can go ahead and take any questions that you guys have.
All righty, great. Thank you so much. So I'm kind of interested in these limb kinase inhibitors. So can you remind me, were they tested just in animal models, or were they tested in humans as well?
They were tested in animal models, mice.
Did they say anything along the lines of maybe just like hypothesizing and increased risk for withdrawals?
Yeah. Oh yeah, sorry, I did not mean to cut you off. Yeah, so that is a potential side effect for it, because when you increase the delta opioid receptor, you might precipitate some withdrawal symptoms. However, if you're able to increase the amount of opioid receptors and still maintain the amount of opioid usage, that cost versus benefit might be a little bit offset. So, the withdrawal symptoms can still be effectively managed without significant medical risks, so to speak. But the risk of increasing opioid concentration poses a greater side effect than the withdrawal symptoms. So I think, it's just a kind of give and take. But yes, withdrawal symptoms are definitely a potential side effect.